Welcome, everyone. I'm delighted to be able to be with you this evening and to have you join our webinar on what the U.S. can learn from the Canadian healthcare system or not. And we have a fabulous webinar planned with two terrific speakers, Colleen Flood and Eric Meslin, who I'll be introducing in a moment. Just as background, the reason that we decided to have this webinar is because obviously Canada and the U.S. share many things. We watch the same TV shows. We go back and forth, many of us. Many of us have colleagues from one country or the other. And yet in other ways, particularly in our healthcare systems, we vary in very important ways. And clearly COVID has manifested a lot of these and highlighted a lot of the differences. Here in the US, for instance, we have become, many of us, even more aware of the disparities. COVID's made us more aware of these disparities than we've been before. There are also many in the US who look with envy to Canada as having what we see as a national healthcare system in a way that we in the US lack. On the other hand, there are those in the United States who decry what they see across the border, saying, well, that's socialism, and that's something that is anathema to American values. So we thought we would sit down with some experts now and think about what are the similarities, what are the differences, and importantly, what can we learn from each other, if anything, the challenges that each of our country faces in terms of healthcare in upcoming years, in terms of rising costs, in terms of disparities among different groups in the population, are challenges that are going to remain with us. And we can best understand how to move ahead by understanding why we are the way we are, how we got to be in the places that we are, and what we can think outside the box that might be helpful in one way or the other. And so we have two terrific speakers, as I mentioned. First, we have Colleen Flood, who will be speaking, and she is a professor at the University of Ottawa and is a university research chair in health policy and law. She is also the inaugural director of the University of Ottawa's Center for Health Law, Policy and Ethics. Before that, she was a professor and Canada Research Chair at the Faculty of Law at the University of Toronto, with cross appointments in the School of Public Policy and the Institute of Health Policy Management and Evaluation. She was also the scientific director at the Canadian Institute for Health Services and Policy Research. She has worked for a number of years on comparative health law and policy in other areas, and we're thrilled to have her with us. We'll then be hearing from Eric Meslin, who is president and CEO of the Council of Canadian Academies. He joined the CCA in 2016 after 25 years in university and government settings, including the previous 15 years at Indiana University here in the US, where he was the founding director of the Indiana University Center for Bioethics and an associate dean for bioethics in the medical school there, as well as professor of medicine, of philosophy, of medical and molecular genetics, of bioethics and law, and of public health. And I think that speaks to his wide-ranging mind and openness to many disciplines. He trained in bioethics and philosophy at York and at Georgetown. He's taught at Cambridge and elsewhere. He's published over 200 articles and book chapters on bioethical aspects of genomics, international health, big data, and other areas. He was also the bioethics research director in the Ethical, Legal, and Social Implications program at the National Human Genome Research Institute here in the US, an executive director of the National Bioethics Advisory Commission appointed by President Clinton. So he obviously knows both sides of the border. So without further ado, please join me in welcoming Colleen Flood. Thank you for joining us.
Thank you so much, Bob. And I've got a little bit of feedback here, and lovely to be here, especially with Eric. We've worked together before, and this is such a great pleasure to be able to speak to you today. So if we could put up my slides, if that's okay, Matt. The first slide, please. Thanks. So when Bob asked me to participate today, I thought that perhaps it might help us to sort of kind of pull back a bit and think about healthcare systems from the ground up. And to me, it's not so much about what Canada can learn from the US or vice versa, but what we can learn when we look across comparatively more generally. Oops, that's my dog falling down the door. It's always something on a Zoom, isn't it? Oh my goodness. So what we can learn when we look across different healthcare systems, and what we see when we do that, is that in every developed country in the world, apart from the United States, there is a commitment to universal healthcare. And I think that's what actually distinguishes the United States amongst OECD countries. So really comparing US and Canada is not the question. It's more, why is the US different from all other countries in the developed world, not just Canada? So if we go to the next slide, please, Matt. There's no doubt that healthcare reform in Canada, is a subject of perennial debate, as it is in the United States. And we do tend to look across the boundary, the border for inspiration or guidance. And I think what we mostly do is just politicize stuff, so politicization of the US system or politicization of the Canadian system without really digging into the specifics. And I think, though, in the specifics, you will see that, this idea of Canada having a national healthcare system is actually incorrect. We don't have a national healthcare system. Sort of ideas about Canada as a socialized healthcare system are also incorrect. So I'll try to explain that a little bit more. But basically we see conservatives and progressives on both sides of the border using this sort of comparison between the two healthcare systems as just a way to politicize the same old debate. And really, when you think about, if I was in the US looking to Canada, or Canada looking to the US, it is a wee bit, as this picture is trying to convey, a bit of the blind leading the blind. And what do I mean by that, Matt? If we could go to the next slide. And that's because, when we do look at healthcare performance, and a lot of pointy-headed people spend an awful lot of time trying to figure out how we can measure how different healthcare systems perform. And there are a variety of places you can see these sorts of comparisons, and there may be differences, small differences over time, but what's consistently pretty true is that the US does not score very well from a healthcare system performance metric, but then neither does Canada. So, I often say to Canadians who sort of take some solace in what seems to be a not well-performing healthcare system, that at least we're better than the US. It's a wee bit of shooting fish in the barrel. And then from a US perspective, it's certainly not blisteringly clear that Canada's system is the one that, if you're looking to reform, that this is where you will seek inspiration from. So if we go to the next slide, please. One of the things that we do have in common is that, putting aside the politicization of Canada's system is socialized and the US system is privatized, you actually see that this is completely incorrect. And the US has massive public health care programs for Medicaid and Medicare and veterans and all sorts of piecemeal programs all over the place, which means that, a great share of, close to 50% of the system is actually financed from tax coffers. And whereas Canada, compared to other OECD countries, actually has quite a big share of its finance coming from the private sector too. So it has about 30%. So when you realize that, not that that is completely insignificant, but we're actually not that different. And in particular, the Canadian healthcare system, we do not include within our universal system many things. So the things that we include are hospital and physician services. We did that in the 60s, and then we stopped. And we haven't really moved to include many other things within the universal healthcare system, like prescription drugs, for example, or dentistry, or home care, or long-term care. In those fields, in those sectors, we have US-style healthcare. We have private health insurance. I have private health insurance through my university employer. I'm sure Eric does too, through his employer. And that covers those of us who are lucky to have private health insurance. Government covers the poor and the elderly, and there are a bunch of people in the middle that miss out, which seems to be the case whenever you take that kind of approach to funding your healthcare system. So in fact, more Canadians hold private health insurance than Americans, at least that was the case a couple of years ago, because so many of us have private health insurance for prescription drugs, which is kind of an interesting thing. Now, the other thing about the Canadian healthcare system, sometimes, as I said, the politicization of the system is that, it's socialized or nationalized. And that's actually far from the case. So a nationalized healthcare system would be one in the United Kingdom where hospitals are actually owned by the government and physicians are employed by the state. That's not true in Canada mostly. Physicians in particular are paid on a fee-for-service basis and are independent, self-employed contractors. They mostly send their bills straight to the government, who pays it very promptly, and they don't have to muck around to get their money. But they are not, overly controlled by the state. And in particular, I think it's interesting that they have a lot of clinical autonomy. So unlike some of the measures and strictures that you see in the US from HMO providers vis-a-vis healthcare providers, we don't actually have that much in Canada. No, so I think the thing that one would think from a US perspective and from a Canadian perspective, given all the money that we spend on healthcare, relative to other countries, if you see the US here is, the sticker shock of what is spent is pretty up there, and Canada is quite high relative to other countries as well. So, okay, well, that's fine, right? I mean, you spend more, you get more, one would assume. But if we can go to the next slide, please, Matt, we see that really that's not the case. So if we're looking at hospital beds per 1,000 inhabitants, we see that Canada and the US is really quite low relative to other countries. So we're not getting necessarily, it seems, more hospital beds per capita. If we go to the next slide, please. Nor does it seem that we're getting more doctors per capita either, right? So we're kind of down the bottom of the pile when it comes to doctors and hospitals. But if you go to the next slide, please. But when it comes to pharmaceutical spending, we're a doozy, right? So we're spending a lot on pharmaceuticals. I'm not sure that it's clear at all, though, that we're actually getting more prescription drugs per person, but we're certainly paying a lot more for the same thing. And I think, it's not really a coincidence to me that Canada's spending on pharmaceuticals is right up there with the United States, because we too have a sort of US style approach to financing of prescription drugs with fragmented coverage. We don't have a universal system. We have insurance for our private employers, and we cover the poor and we cover the elderly. So I think, and maybe Eric will speak to this a little bit more, but from a philosophical perspective, I think most of us feel that there is, an ethical imperative to make sure that people have access to healthcare. If they can pay for it, that's fine, they should pay for it. But many people can't pay for it. And so one way or another, the state is going to get involved. Even in the United States, as we saw, where there's much more of a feeling or an ethos of individual autonomy and self-responsibility, there are still, very extensive programs for the elderly and the poor and those living with disabilities because of this ethos. And I think, what one finds then is once you combine that sort of ethical imperative with the economics of healthcare, that's why most of the healthcare systems in the developed world gravitate towards a universal plan. not because that's ethically or philosophically required, but because of the economics of it. So if you can move to the next slide, please. So, when we live in capitalist societies, and the wonderful thing about that, if you follow the model of Adam Smith, is that the resources are allocated as they should be, with us all running around buying our Louboutins or our apples or our houses or whatever it is that we wish to buy, and products are manufactured and produced for us, and there's price competition and all these kinds of good things. But what we see with healthcare is that there is massive and significant market failure. The market doesn't function well in this sector, and that's why you see so much and so extensive government intervention in these markets, whatever system you're in. So the first assumption that we have in markets is that there's sort of complete information or perfect information. I know what the relative costs and benefits are of any particular product, and I know what the alternatives are, and I can move around in the system. The other one is a lower transactions cost, and the other one is sensitivity of demand to price, or what I would call moral hazard. So if we go to the next slide, please. So there is, a very significant gap or market failure in healthcare because of the information gap between physicians and patients. Essentially, a physician tells me when I go to see them what is wrong with me, and then they tell me what I need. I can't really shop around very well. I first need a diagnosis before I could even do that. And then in many situations, I simply have no ability to shop around. I may be in a car accident or very unwell, very sick. It's really quite difficult to go price shopping at that kind of point. So there is this huge information gap. That's why we train physicians, nurses, pharmacists, and dentists for many, many years. So they acquire this body of knowledge between them and the patient. And that means you cannot sort of view the patient as sort of a typical market consumer, a savvy consumer in the marketplace, as we would in many other areas. So if we go to the next slide, please. Now, you combine this problem of the information asymmetry with something we call moral hazard, which sounds sort of way more fun than it actually is. And that is essentially the problem, that there's insensitivity to the price of the healthcare. And partly that might be because of the importance of the need, right? So if I'm taking my son to emerge or for some kind of treatment, cancer treatment or whatever, because it's my son, there's all sorts of reasons why I don't want to ask about the price. The price be damned, I will pay whatever is needed to be paid. But the other problem is that we also run out, and either we get health insurance from the private sector or we get public health insurance. And we want that insurance so that we don't have to worry about the price. But once we have that insurance, we don't worry about the price. And that leads to insensitivity to price. It means costs will always go up and up and up and up because of this problem. And I've just got this picture of cetirizine here. I suffer seasonal allergies, and living in Ottawa, I tell you, I moved from Toronto, and it was a stunning revelation how awful it is here for seasonal allergies. And my private insurance had clocked over a year for some reason, and I had to pay pretty much out of pocket. I asked about the price of it. They said it was, $88. I asked my husband, who's a pharmacoeconomist, about this particular drug. He said it's a generic drug. It costs actually, cents to produce. So I couldn't understand why it is so expensive. And in New Zealand, which is where I'm originally from, and my husband used to run the drug plan there, the New Zealand government, because they have a universal plan for prescription drugs, and the government bargains with the drug companies for better prices for all of New Zealand. The same drug, which I paid $88, or my insurance plan continues to pay $88 for, because I don't really care about it, except when I have to pay out of pocket. In New Zealand, they pay $2.88 compared to $88 here. So I think you see something of the problem. Matt, could we go to the next slide, please? And the problem is basically prices. So in countries where, or in systems where there is not a universal system and there's not an attempt to try to extract value for money from the expenditures that you make as a consequence, because the costs are kind of hidden, you basically pay a lot more. And so here you can see some comparisons of the percentage of prices that are paid in other jurisdictions for similar services. And if we can go to the next slide, please. The other issue that comes up is in private markets is the problem of adverse selection. So this essentially is because insurers can't know or can't have perfect information themselves about the risks that different individuals have. For example, choices or lifestyle choices or circumstances that individuals have found themselves in that aren't revealed through the questionnaires and so forth that you have to fill out. They price their insurance products at a point where people who know that they're very low risk feel that it's priced too high for them, and so they don't buy the insurance. That's an economic problem. A moral or more ethical problem, of course, is that insurers have an incentive to try to weed you out of the pool if you are high risk or you have multiple comorbidities. So, the irony is of private health insurance is when you really need it, that's when they don't want you. And when you don't need it, that's when they want you. And so that, is a significant problem. So I put this next slide up, Matt, and I was wondering if Bob was going to ask me about this before we started, like, are you sure you really want this picture of satin underpants on your slide? And I do, because years ago I saw a presentation by Uwe Reinhardt, who's a fantastic economist in the US, and he showed this slide, and it had everyone falling about laughing. He had it was obviously his silk underpants splayed all over a hedge in his garden. And he said, this is my real insurance policy in the US, because if I ever get run over or hit by a car, they will know I am a wealthy man and will treat me well because I have silk boxer shorts. So next slide, please, Matt. Now, the other factor that is often pointed to from these sort of more fragmented systems where you have some public, some private, out of pocket, multiple private insurers is simply the weight of the administrative costs, the administrative burden that has to be borne. And it's clear that that is a lot higher than the US. So for Canadian healthcare providers, life is a bit easier in lots of ways, because the bill is just sent to the government and the government pays it. So, the amount that you receive might be can be lower, but on the other hand, you don't have all of this hassle. I don't think this is necessarily a slam dunk for and against any particular healthcare system, but it is a factor. So if we can move to my last and final slide, I'm sorry about the glitch in the middle. This, I sort of have this saying about it's all rainbows and ponies, and it's certainly not rainbows and ponies in the Canadian healthcare system. We have significant challenges that we're wrestling with to try to improve access, to reduce wait times. Particularly after the pandemic, healthcare providers are crushed and burned and exhausted and tired. There is so much to do. We need you know, we need to figure out how to stretch our resources. It seems so difficult to move to expand our healthcare system to try to cover better dental care, which we know is so intricately linked to cardiovascular disease and other health outcomes, to improve access for prescription drugs. We don't even necessarily cover access to insulin for all Canadians. A wonderful innovation actually founded by Canadians. So there is much work to be done, and you know, we struggle with this in Canada, I think, every single day for those of us who work in healthcare policy. And so I don't think that Canada can come and tell the US what to do in any shape or form, but neither do I think that there's much for Canada to emulate in terms of thinking that privatization, the US sort of version of it, is going to help us with any of our problems either. So thank you very much, Bob. Sorry for the glitch in the middle, and I'm really looking forward to hearing what Eric has to say.
Great. Well, thank you so much. And just a reminder to our audience, we see this as a very interactive session, so please feel free to put in comments, questions, and we'll have a chance to answer those. So without further ado, Eric, welcome and thank you.
Thanks very much, Bob, and Colleen. Thank you for really a fabulous presentation. I'm going to put up my slides and hope they are visible to all. So really a number of thanks to begin with. One, thanking Colleen for her presentation. We didn't chat in advance, but I think my remarks can complement hers without occasionally mentioning a few similar points, but without going too far into the redundancy side. I do feel that I should make a couple of disclosures and acknowledgements typical of academic presentations. You heard that I've got a position here in Ottawa running what we sometimes charitably call Canada's equivalent of the US National Academies. It's much smaller, but that's what the Council of Canadian Academies does. It carries out assessments of work. But I'm speaking here in my private capacity, not on behalf of the CCA. Secondly, and I probably could have added Colleen's name to this, the topic for today is not something that I have just had my arm twisted by Bob and his friends. I've been thinking a lot about these issues for a number of years, and I've really benefited from conversations with colleagues in many parts of the world, but principally over and across the 49th parallel, the actual latitude that separates the two countries, some of whom I'll mention in more detail, but some colleagues, Aaron Carroll, Philip Hebert, Nancy Jecker, Sheila Kennedy, Fred Lowy, Peter Schwartz, Bill Tierney, and Ross Upshur are some of the friends along the way who I've tested out some ideas on, some of which will come up in the presentation today. And then secondly, I think Bob alluded to this, I have lived and worked in both countries for many years, born in Canada, born in downtown Toronto at the Mount Sinai Hospital, and then decamped to the US for really more than 20 years, where I lived and worked and experienced the country, studied it, and the like. And that doesn't make me an expert on either country. In fact, I probably am the least expert on both, because I'm somewhat biased now in ways that might be helpful. So just a quick set of disclosures and acknowledgements. I want to begin with what, and I don't want to say the line. I hope this isn't too small. But what you're seeing is an accumulation of a completely informal, non-scientific, alphabetically organized dashboard of a variety of health indicator comparisons. Some of them Colleen mentioned. What you will see going from A to W, that's the alphabetical order, with occasional insertions of Canada or US flags, are examples of different kinds of healthcare indicators, simply to make an obvious point, and then hopefully a slightly more nuanced point. The obvious point is that all indicators are not the same. Some of them are about health outcomes, some of them are about risk, some of them are about health status. There are more than you can see on this chart. I'm using the rule of not putting too many things on a PowerPoint slide, and it's already at about 15 point font. So just to give you an example, and this is not meant for the critique space on the chats, but I'm happy to talk about any of these. You will see some stickers like COVID-19, deaths per 100,000, with a Canadian flag next to it. That's because our deaths per 100,000 are much lower than the deaths per 100,000 in the United States. That's why it deserved a Canadian flag. I've not yet said whether that's good or bad, although obviously it should be quite good to have a lower death per 100,000. But there are others, and again, forgive me for my for the way the screen the slide shows. On my screen, the flags are perfectly aligned with the dot points. You will also see examples like wait times for surgery, a very important topic in Canada, or mortality rates from cancer. Do not misunderstand when there is a flag next to these. It doesn't mean that one is better or the other is worse. It may mean that one is higher and the other is lower, and we would need to have a longer conversation about what that means. The sources are varied for this, ranging from the Canadian Institute for Health Information, which Colleen has already alluded to, the Commonwealth Fund, Statistics Canada, the CDC. One can go online and virtually type healthcare indicator comparisons, Canada and the US, and pull up hundreds, if not thousands, of papers. So point number one is, when we start to compare, which I think is one of the subtexts for tonight's conversation, in order to learn a lesson, let's not immediately pick our 3 or 4 favorites, like, well, Canada's a national healthcare system. Colleen already if you don't mind me saying, demystified it. We have 13 healthcare systems in Canada, 10 provinces and 3 territories. We also have the federal government as a healthcare system providing certain kinds of care to our Indigenous communities. So looking at this slide, all you should take away from it is, goodness gracious, there are a lot of indicators. I wonder which ones are my favorites, or I wonder which ones matter most. So hold that thought, because we'll return to it later. This slide is really a shameless self-promotion in some ways, and a regrettable observation in another way. You're not supposed to see the picture of the paper. The paper was written by a good friend of mine, Nancy Jecker, and I, almost 30 years ago in theoretical medicine, when we undertook what we thought was an interesting heuristic thought experiment, looking at Canada and the US. And we said the following things. As both the US and Canada are on the brink of critical decisions regarding the future direction of their healthcare systems, this is an especially important moment to reflect upon the ethical values that underpin alternative policy directions. When I reread that paper, I was gobsmacked, depressed, or enlightened, I'm not sure which, as to how applicable those words are today. That wasn't that Nancy and I get bonus points for predicting the future, but I think this statement is a feature, not a bug, of the comparative work that we do in Canada and the US. That occasionally things happen, a new president, a new prime minister, an important event, where we cause ourselves to revisit or think we would like to relearn a lesson that we forgot, or maybe to look forward to future directions based on the past. The second quote that I pull, and I won't keep quoting from my own work, I don't know if that counts on Google Scholar or not, but What we decided in this paper, and as I say, I'll refer to other points in a moment or two, was that rather than just looking at the policies themselves, Colleen alluded to some of the policies. What does the Canadian healthcare system cover? It covers medically necessary treatment, a term that has to be defined in law and practice. And it covers, and was originally designed to cover, hospital care and physician services. Nothing else. That's what it was planned for at the beginning. That may not be all of the things that constitute healthcare. Forgive me, but I'm going to go back a slide to show you this because I really had a lot of fun putting it together. You will see items on this slide like poverty or education. You will also see, I'm afraid that I have to remind us because it happened about 2 hours ago, gun deaths and gun availability as a comparator. Now, I'm not going to get into a public health conversation about gun deaths and gun violence, but given that 14 children were just killed in Texas about 2 hours ago, 4 days after a bunch of people were killed in Buffalo, and we're now at more mass shootings in the United States than there have been days passed in the year, should give one pause. So these are what I might call incommensurable comparators or indicators, and yet we're still having conversations about what the healthcare system is or might look like. So here's what Nancy and I did, and then I'm going to take a deep dive for about a second and a half into 17th and 18th century philosophy before I resurface and talk about the present. The kind of heuristic device that Nancy and I used was to begin with a kind of a presumption that the justice in healthcare debates in both the US and Canada, what's fair, what is owed by the government, what are people entitled to, how do we distribute the scarce resources of people, beds, physicians, medicines, and the like, can actually be traced, not terribly critically, back to the 17th and 18th century social contract theory traditions of Hobbes, Locke, and Hume. I'll give you a slide on each of them very quickly if you forgot who those old white dead guys are. But largely our point was that Canada and the United States were actually similar kinds of countries when you compare them to other forms of government organization. And as Colleen mentioned, it took until the late 1950s and really early 1960s before Canada began having a conversation about what kind of healthcare system it was. You know, for those of you who are playing at home, Canada became a country officially in 1867. When Canada became a country, it didn't have national health care. It took until 1961 to even start the conversation, and 1984, before the Canada Health Act was finally brought into place. So this is a new phenomenon, and yet we have this long tradition of how countries should organize themselves, what obligations governments have to citizens. So as I used to tell my students, Canadians, as much as we might like to think of ourselves, are not genetically nicer or not, phenotypically, let alone genomically, more humanitarian or more caring. We just made a decision about 40 years ago based on long conversations and long discussions. So I do have some biases, and as I said, these are quick slides, not meant to be read as much as reminded. So here's Thomas Hobbes writing in the Leviathan, reminding everyone of what life is like when you aren't living in society. It's a terrible life, one that is solitary, poor, nasty, brutish, and short. And the purpose of government, if anything, is to just protect people against harms. Locke, writing a little later, had a similar view to Hobbes in social contract land, thinking about the purpose of the law in constraining unfettered liberty is to preserve and enlarge freedom for people. Where there's no law, there's no freedom, said Locke. And David Hume, the Scottish philosopher who was friends with Adam Smith that Colleen alluded to before, they used to wave across the Dell to each other, is a bit of the outlier, who in the last quote here you see, every wise, just, and mild government, by rendering the condition of its subjects easy and secure, will always abound most in people as well as in commodities and riches. So the ideas of what government should be and can be are very much, I think, in the subtext of the conversation we're having today, and not because Canada has a queen as its official head of state and the United States doesn't, but that the way it organizes itself and thinks about the role that the government plays with respect to the public is one of the charming and challenging differences. So again, I think I did not test my slide on StreamYard, so I'll have to just let you know what the left side of the slide says. We asked the question, is the U.S. healthcare system, consider this a kind of rhetorical late evening conversation, Hobbesian or Lockean? Nancy and I said, yeah, kind of. It tends to focus on individual self-interest. It focuses on minimal constraints on human freedom. You want to make sure that there are laws. You don't want to get too out of control, and you certainly don't want to tell people what they ought to do. You just want to tell people what they shouldn't do to others. There are contemporary versions of those ancient historians that often begin with Rawls and move on to our friends Norm Daniels and Tris Engelhardt. You can read Norm's bit if you haven't read his book and books. Highly recommended. But I want to just mention the Tris Engelhardt quote, because it was uttered to me at a meeting in Toronto in 1990 when he boasted, and Tris is no longer with us, boasted that not only did he make it over the border with his gun in his boot, again, this was much pre 9/11, of course, but when asked to speak about healthcare and the differences between the US and Canada, he said, I don't really care about Canada because for me, healthcare is actually just a commodity. And yes, it's unfortunate that people might not have it because they suffer a disease, but it is not unfair. It is unfortunate, but not unfair. Now, I'm not suggesting that Tris's libertarianism is the principal, P-A-L-P-L-E, foundation for the U.S. healthcare system, much like Canada's is not communistic or socialistic, even though one of its founding fathers, Tommy Douglas, was politically left-wing. Here's Tommy Douglas. And if you haven't read the history of Canada's father of Medicare, I would encourage you to do it. It's a fascinating story. And again, in the rhetorical version of his Canada's healthcare system, Humean, please read Hume. You can read our paper and come to your own decision. But the differences here are non-trivial because they focus not simply on high-level outcomes, but on what I would call foundational ethical principles of how government considers its role vis-a-vis society. Colleen alluded to this, and this is where I'm glad that we're overlapping a bit. Despite what we might have said in our 15 or 20 minutes each, neither system is either monolithic or unchanging. They're almost tectonic in some ways, moving backwards and forwards towards or away from certain principles of universality and accessibility. You may be surprised to know that Richard Nixon proposed one of the most impressive national health care programs in U.S. history. It did not happen. Nixon, of course, is remembered for lots of things, but that isn't one of them. He was also remembered for, starting the EPA. I'm no Nixon fan, you can be sure of that. But you can also see that Canada's charming history of adopting universality and accessibility and the like was relatively new and is not universally regarded as desirable across the entire country. What I was referring to before by mentioning Colleen is the 6 bulleted programs that are government-run programs from Medicare through the TRICARE programs at the DoD cover about, if not a little more, 100 million Americans probably a little more depending on how you count. That includes the VA, the Indian Health Service, and the like. Obamacare, the Affordable Care Act, again, depending on how you count, 31, 32 million Americans now covered. That's, you're getting close to half, if not more, once you start doing, the pencil sharpening. These are significant amounts, especially when you realize that 31 million is only a few million short of the entire population of Canada. Now, again, Colleen alluded to a number of things, so I'll go over this extremely quickly. There are areas not covered by government plans: dental, prescription, home nursing, vision, long-term care, fertility drugs, and a big long list. I did bring as a show and tell, here is the booklet that I received from my Canada Life insurer that lists all those procedures and treatments and health professionals that are covered because I received this benefit as a function of my employment. Everything from acupuncturists to podiatrists, custom-made compression hose, wigs for cancer patients, outdoor wheelchair ramps, continuous glucose monitoring, etc., etc. A big long list, 60% covered, 80% covered, the rest out of pocket. Now, to close, I sort of am asking, and again, I don't understand what the overlap is, but I know what the words are. This presentation today sort of began with the presumption, what can we learn from whom? And I think you're hearing, it depends on what learning means. Don't do this, or please do that, are different forms of learning. But I wanted to leave us with kind of a reminder that is the bookend to my big table at the beginning that listed everything from abortion to wait lists. And that is, be careful how you be careful how you compare. Comparing Canada versus the United States is, to me, it's a fruitless comparison at one level, apart from very big numbers over long periods of time, because it would be just as sensible for Canada to compare itself against a country that has either a similar healthcare system or similar governmental system like the UK, or is similar in size, or is organized in similar ways. The top left corner is not meant to be exhaustive, but Canada and the US are compared because we share the world's longest undefended border. And that may be the only reason. We should be comparing ourselves to New Zealand, Australia, or Germany if we wanted to be more accurate. Or think about the lower left. There's a difference within Canada, a strong difference, which we've noted even during COVID, about access to tests or availability of vaccination. Comparing Ontario to British Columbia is very different from comparing Alberta to Manitoba, or a large, rich country like Ontario to a very tiny island country, province like Ontario to a very tiny province like Prince Edward Island. And the same is true Toronto versus Vancouver, Montreal versus Iqaluit, which is how that is pronounced in our far north, or Ottawa versus Calgary. The flip side of this table, you will see other forms of comparisons which provide different kinds of dashboards or benchmarks. I just want to close with one kind of sentimental comparison. I live in Ottawa and have for the last 6 years, and for 15 years I lived in Indianapolis. I am not ashamed to say that the quality of healthcare that I received in Indianapolis as a member of the Indiana University School of Medicine, and the healthcare system and insurance plan that I was a part of, was superior in many ways for me. Not so much the Uwe Reinhardt version. I don't have silk boxers, but I was a well-paid member of the medical school at one of the largest employers in the state, which had a very active and progressive program for making care available. I had to have a lateral meniscectomy on my right knee and went to see an orthopedic surgeon who happened to be the surgeon for the Indianapolis Colts and the Indianapolis Pacers, the football and basketball teams. When he evaluated me, he said, I said, when can we get this done? He said, how about Thursday? of that week. Now, that is an anecdote, and as we all know, the plural of anecdote is not data. Just like it would not be fair to say that when I arrived in Ottawa 6 years ago, it took me about 11 months to find a primary care doctor, which is the gatekeeping mechanism in Ontario for finding other specialists. This is not to disparage Ottawa any more than it is to highlight Indianapolis, but I do wish to sort of close by reminding us that when we compare, it's not just about outcomes, it's about values and principles. And again, using the rule of not putting too many things on a PowerPoint slide, and these aren't even organized alphabetically. These are the kinds of topics that have been coming up over the last 30 to 40 years in both countries. And I just close with the question, what values and principles do we wish to see in our healthcare systems? Thanks very much.
Well, Eric, that was great. And clearly, I think each of you come to these issues with, in some ways, similar, but also very different perspectives, which is wonderful. So we have a number of questions. And again, people who are watching, please feel free to ask questions. Don't be shy. Here's a question from Christy Kirshner. Who pays for chronic care, disability care in the Canadian system? Do you have a more robust long-term care system, home and community-based services? So, Colleen, maybe do you want to start on that?
Sure, and then we can go to Eric. The disability, whether you're disabled, whether you're injured, or however you've acquired your healthcare need, nearly all hospital and physician services are completely free. So you never have to pay for that. However, for income replacement, so if you are disabled and you're seeking income replacement, then this will depend on whether you had that kind of insurance through your employer, and if not, then you're going to be falling back onto social assistance. Sometimes if you have a workplace injury, there may be compensation through workplace compensation schemes, but it's a mishmash, and as I understand it, quite similar to the US, except for the fact that the healthcare part is almost completely free. Long-term care, we actually are fairly similar in how miserable we are in funding our long-term care services, and it actually varies from province to province in Canada quite a bit. Some provinces have kind of an income test. Others, like Ontario, actually where we are, don't. But there are long wait times to get into the publicly funded nursing homes as a result. But even if you're a millionaire, you can, in theory, go into a publicly funded nursing home. You have to pay some amount. But, the problems of our long-term care systems across Canada and the US are fairly similar. So this has been a gigantic topic of conversation here post-COVID, because the terrible state of our long-term care system, both in Canada and the US, was sharply revealed by the COVID-19 crisis. But I'll let Eric add what he would like as well.
I think, Colleen, you summarized it perfectly. I didn't realize that bringing my little show and tell would be so valuable, but I can tell you what my long-term disability income benefit would be as a function of my, right? If you were interested, it is listed in a book. So if you have, are fortunate enough to have that kind of replacement insurance, then it covers what it covers for a period of time. There may be waiting periods, there are conditions. In this case, it is completely indistinguishable from the US system, insofar as it depends on which insurer, of course, is insuring you. And I would also highlight, without having to overstate, because it's impossible to overstate, what COVID revealed about the very sorry state of long-term care, which includes such worrying revelations. And one of our colleagues, a celebrated journalist for the Globe and Mail named Andre Picard, wrote quite a detailed expose, I suppose you would call it, on some of this recently. But what I think it revealed, among other things, was we don't have a well-regulated system. I included again on that chart that needs to be updated, the red tape or administrative burden that Colleen alluded to. And in some areas, that is one of the principal impediments to access, certainly in the US, access to care. But Canada is no, shrinking violet when it comes to its own areas of red tape. And one of the areas that this was revealed was waiting times and criteria for access to assisted living, nursing care, what we used to call old age care. Canada has a system of social security with old age pensions and a variety of other safety nets below which you will not tumble. And I suppose it doesn't warrant repeating, but I'll say it anyway because it's among I think the things that Canadians believe they are most proud of. The system is regularly regarded as very, very much enjoyed, although in recent years public opinion has gone down. And that is you will not have the case examples of people going bankrupt and having their houses foreclosed. I mean, among the things that you sort of fall back on, what is it about Canada? I don't like this or that president. If you're a Republican, I'm leaving that when Obama came in with the ACA. And I can't tell you how many colleagues when Ronald Reagan and George Bush came into power said, are there any openings in any Canadian university anywhere? Don't care. We'll work for food kind of thing, because I can't stand living in a society where people will die because they don't have a job. That's just bizarre. So our system is still patchwork, as Colleen described, and I think the highlight of long-term care and assisted living is an area that we have to make peace with very soon.
Yeah, I would just add to that, Bob, that I do think that, again, it's quite important for the US to reflect not just on Canada, but the rest of the developed world. And, just to repeat the point that this is true, that you will also not get bankrupt or lose your house in Germany, the Netherlands, the United States, Switzerland, Sweden, Norway, Australia, New Zealand, let's go on and on and on and on. So to me, that's the minimum, right? And then the devil's in the detail of how you get there. And to me, when Eric is talking about values, that's where the values really come in, because to me, the ethics and the economics say universal coverage is the way to go. Once you admit that you're going to cover the poor and the elderly, then the economics kick in, and it just makes no sense to have a fragmented system, because all you do is pay high prices for not very much. Once you go for universality, then you can go the Dutch model, right? The Eindhoven managed competition model, where, which is sort of a little bit behind the Affordable Care Act, where you regulate private health insurers to achieve universal access. There's many ways to skin the cat, if I can use that rather unfortunate metaphor, to get to where you want to go, and still keep your values of autonomy and, a bit of libertarianism, where you draw the boundary about what's in and out. If you're a conservative, you'll draw that a bit more tight, right? You will say, we will really be hardcore about what is medically necessary and not. And that's how you will do it. But you will still then just save bucket loads of money for your constituents by doing that. So that's how I see it anyway.
It's interesting, as you're talking, just as an aside, I'm thinking what Canada represents for many Americans in healthcare debates is the fact that it's near us. And so we might say, oh, the notion, well, they do that in Europe, and so we should follow that here, is not going to sell as much as in isolationist America, as much as saying, well, they do it in Canada and kind of works, so maybe we could do that here as sort of a model. So
Yeah.
Europe just seems so much further away, and therefore, at least in some people's minds, even less applicable.
You see, I'm from New Zealand, so that seems real close.
New Zealand, yeah, so of
Yeah.
course, and of course, what does that mean that Europe is far away, et cetera, especially these days? Connected.
The comparative question is, I think Eric is right. You have to try your best to compare apples and apples and oranges and oranges. But again, the US is such an outlier by not gunning is a terrible word today, but aiming for universal health care. Yeah. So that's what makes it an outlier in the world. And but if you make that your aspiration, then how you get there are so many different ways to do it. I don't think, to me, because Canada has such a disaggregated federation, as does the United States, that the comparison is as not as applicable as Eric thinks. I think that we do have things in common from that perspective. When I do comparative work, I usually do include the US, Canada, and Australia as quite disaggregated federations. Being a federation makes life difficult for governance in healthcare. It's much easier in the UK and New Zealand, where I'm from, because it's a unitary state. So once they make up their mind they're going to do something, they do it in 5 seconds flat. Whereas particularly in Canada, there's so much debate and arguments about what level of government is allowed to do what and when. And even if they're doing the right thing and everybody likes it, someone's just going to object to it as a matter of politics. So it's, it makes movement really, really difficult. And I think, there is similarities in that regard with the US.
I think Colleen's right. I know you're going to go to another question, but I can't resist because she's completely right. And I think my point about the apples and apples was less about we shouldn't, but to pick the right one. I mean, I'm watching just access to, you want to talk about another third rail, access to abortion services, right? And if you look within the United States, you can find as much diversity state by state without ever leaving the country. You don't even have to ask, what do they do in Canada, or what do they do in Belgium, or what do they do, right? Just look at what the governor of Illinois is facing right now, as he stands on his principle of providing services, knowing full well that the bordering states, Indiana and Michigan, they're all going to be coming in. And Texas is deciding what it's doing. So it's less about I think I'm more concerned about the kind of cartoon version of a characterization that is not helpful, rather than the actual comparison that I think there are things that we can learn from. Canada did a spectacular job in rounding up its scientific community to sequence the SARS coronavirus. They did it in nothing flat. They did it for free. There wasn't there's things within a system that can be learned elsewhere that wasn't uniquely Canadian. Anyway, you could see Colleen and I like chatting with each other, whether people are watching or not. So I'll let you do that.
Sorry.
That's all right. Great. I was going to say, by the way, commenting on where we're at, is I was surprised and somewhat inspired by the fact that the Canada system didn't come into play until 1984. In other words, it's not something that's sort of always been there. That's comparatively recent.
Well, it's actually, the hospital services and physician services, they did come into play in the 60s. It was solidified in the Canada Health Act in 1984. And that's where we got a sort of a big normative bang from the federal government that it would be fully publicly funded. So up until what was happening is that physicians who were railing against the public healthcare system were extra billing, so charging patients above and beyond what they were getting from the government for seeing them. And so in 1984, the federal government brought in this legislation to consolidate what had been the Hospital Act and the Physician Act. But yeah, it was in the 60s. So it's really in the 60s that you see, so 50 years ago now or more, that you see the departure between the US and Canadian systems, because actually, if you see them on a graph, they're really tracking along very similarly in terms of coverage and private health insurance roles, and then they start to wildly diverge at that point. Yeah, but right now we're talking dental care. So the federal government has done a deal with a smaller party to basically stay in power because they're in a minority government, to bring in some version of dental care by the end of this year, which is very ambitious for everyone earning less than $90,000. So if this comes to pass, this will probably be the biggest expansion of Canadian healthcare we've seen for 50 years.
So we have some other questions coming in. Does any province come close to having a system that you would regard as just and fair? Which province scores highest in producing positive health outcomes? And of course, I'm thinking of Eric's problematizing that for us, what that means. But any responses?
Who's yours, Colleen?
They're all, I think I haven't seen any data to suggest that, any particular Canadian healthcare system is a stellar performer relative to another. And, some of our provinces have a bigger struggle because they are smaller and have a more elderly population. So, for example, in the eastern provinces, Nova Scotia, Newfoundland, and those ones. In the west, in Alberta, British Columbia, we have a younger population, and so they tend to look a little better on paper. But when you're doing the calculation of performance, you sort of allow for the fact, you adjust for the fact that you've got a younger population. So I don't think we've seen any great examples. I'm actually quite a fan of the Alberta healthcare system, which is, I think, runs a pretty tight ship. So they're usually run by a conservative government, rather ironically, but they actually run a pretty tight ship. They organize their systems well. They keep their physicians pretty happy by giving them lots of money. And it's relatively seems like a high-performing system. So I had a colleague, I'll just mention, a friend of mine who passed away a couple of years ago, Cy Frank, who was an orthopedic surgeon in Alberta. And he put together a wait times initiative where he, as a surgeon, he just studied all the evidence about how to manage wait times, and then he put it into practice. So he basically made sure that no patient fell between the cracks, in all the silos that are in our system, and moved them all forward. And just with actually hardly any money, he got rid of wait times in Alberta for hip, knee, and joint, which is pretty spectacular. So, this is just an example of when you want to do it, when you want to improve the healthcare system or Canada's healthcare system, we can do it, but it requires a bit of political will and a bit of moxie and a bit of savvy.
My answer dovetails right on top of Colleen's, almost as if it were designed. It was her comment about we can if we want and political will. I think the reason why it's hard to answer is not so much because of the way I problem it, based on what, as people watched COVID unfurl, their only awareness of how well Canada was responding to COVID was based on the press release, the press statements coming out of the chief medical officers of health for different provinces on the 6 o'clock news. And some of these people were spectacular communicators of medicine and health and science. I'm thinking of, our colleague in British Columbia, her name is Bonnie Henry, who was well regarded as able to communicate seriousness with the calmness. And as you know, Bob, from your own background, sometimes it's the way something is presented that gives people confidence in something. Data be damned. If the person speaking to me says things are going to be fine, the medicines are going to come in, this is why a mask mandate is going to be in place, and they trust the messenger, as Truman said, you can get a lot done if you don't care who takes the credit. And in the case of the political moxie that Colleen was referring to, one of the advantages of being a country, the second largest landmass in the world, with a population the size of California, is that there is by necessity an opportunity to communicate. In fact, that's one of the original threads of why it was that Canada's healthcare system became a quote unquote system. I mean, there was a farming mentality and help your neighbors, and demography was not so much destiny, but there is a demographic component. And yet at the same time, Cy Frank, Colleen's colleague, who's a legendary figure in Canadian health, and others are often allowed to, encouraged to come up with ideas. We've had no shortage of royal commissions and assessments done by learned panels and committees, plenty filling the bookshelves. But oftentimes it takes a willing and able leading politician to say, I'm interested. Let's work on that. Sometimes it's a disaster, the plane crashes that leads to the reform. But there have been examples. There's another one, and we don't have time to talk about it, that related to the sequencing of the COVID-19 coronavirus. Government threw $50 million in, said, let's get this done. A number of things can happen. So it's a question of whether the system is nimble enough to move to reform, not just whether it is set in concrete and can't move for historical reasons. Canada, the U.S. wasn't like it when Benjamin Franklin was talking to, the European court about the U.S. either. So they weren't born in the same way. Anyway, lots to do there.
Great thoughts. Great insights. From Sue Reagan, a question. Can you describe how the mental health system fits in the Canadian system? Are benefits universal as they are with hospital and physician care?
Yeah, so the mental health care system, if you are seeing a psychiatrist or you need that kind of care in hospital care, that's all fully funded. However, we have do not necessarily cover psychotherapy. So we cover psychotherapy if it's provided by a psychiatrist, but not by a community-based psychotherapist necessarily. Some provinces cover a bit of that, but it's not a universal coverage issue. So it is a really significant problem, quick access to psychotherapy services. Most of us who have private insurance have it covered through our private insurers, but of course the people who potentially need that the most is sort of primary and preventive care, unless they're really quite sick, and then they'll be getting it through a psychiatrist, they may not be able to access it very easily. So again, there's a lot of debate and discussion about basically expanding our publicly funded healthcare system to include more and better access to psychotherapists, or as we think about the advent of artificial intelligence, I was talking to Bob about my interest in this, that could also really help family doctors and general practitioners provide better primary and preventive mental health care to their people that they look after. So that's another possibility. But yeah, we don't cover psychotherapy. And I think it's always this problem of what is medically necessary, right? Same with dental services. A lot of what dentists do to you is simply not medically necessary. It's, whitening and blah, blah. And then, the worried, we could all go see a psychotherapist. I don't know about you, but I could be there every day potentially. So how do you kind of cut that off and make sure that it is medically necessary care that we're funding from the public purse, and discretionary kinds of care, or more consumer-oriented kinds of care that you would like but don't actually need, that we don't fund that? So that's always a really big question in universal healthcare systems and public healthcare systems, how you draw that line. And and I think, things like dentistry, psychotherapy, we've too often seen that as sort of a luxury as opposed to essential, at least parts of it. Yeah.
My 2 cents of addition are not especially enlightening, except maybe to point out 2 things. One is we can put together our grocery list of what the system doesn't have, which we would like to have. We've already identified 3 or 4: mental health care, dental care, some form of social service, particularly at times of urgency. Vision care is routinely covered in private plans. I could not function without these. They're occupationally necessary, and I suspect therefore medically necessary. So point number 1 is we don't want to kick the can down the road. Everyone agrees. Pharmacare was a platform plank in our recent election, covering those drug benefits that Colleen was alluding to. So that's 4 things right there. We can do the math and come up with a number like, childcare has been part of the Canadian discussion and recently passed $10 a day childcare. Well, where does the money come from? One of the things people would say or think they believe is that care is free in Canada. Of course, nothing is free. Taxes pay for things, but you don't feel that it costs you if it's already removed at source. And this is where that politicking becomes quite challenging. Among the required hooks to, in a sense, compel or ensure universality and access and public administration and the like, is that the government has the ability and is required to pay the provinces, who are the individual insurance companies, so to speak, what are called equalization payments. Clearly, the tax base in Ontario is much larger than the tax base in Prince Edward Island. And to say that any Canadian who needs to go into a hospital for heart surgery, whether they're in Charlottetown, Prince Edward Island, or downtown Toronto, should have the same basic level of care, that would be impossible unless the federal government said, we're going to smooth things over to ensure that provinces get support from the federal government to do what the provinces are providing. And yet for many years, certainly since the mid-'80s, the line of federal health transfer payments or equalization payments was going from the top left to the bottom right. Fewer and fewer dollars going as a result of federal government saying we've got to tighten our budget, we've got to do this or that. Well, it goes up as one would expect every now and then drops down. So there are only so many levers that a federal government has. And, that's why I'm not a politician and could never be one, because I'd want to give it all to everyone and say, just, do we really need to have tanks or something? But that's a story for another day. Colleen's better at this than me.
It's just to underscore, though, sometimes it is a false economy because we think we can't afford to fund it publicly. So we end up, saying we're only going to fund certain populations and, when the moon is in Aquarius. And then we have these fragmented systems as you have in the US, as we have for pharmaceuticals, for example, and we end up paying the highest prices for, a generic drug that costs cents to produce. So, I hear our politicians saying, well, we already spend a lot on healthcare. Well, we do because we spend a lot privately, So when you spending a lot privately, it drives up prices in the public system. So as we're thinking about dental care here, for example, one of the problems we have is that even with the public programs that we have, for example, for poor kids in Ontario, a lot of the dentists won't take them because they're difficult patients. They might miss their appointments, and they would prefer to take my kid with a nice private insurance plan who doesn't actually have any problems with his teeth and you're going to get paid the same or even better. So you've always got this problem of politics. And I see a question in the chat about, physicians' resistance to public plans. And let me tell you, there was a huge fight here in the 60s and through the 70s and 80s with government fighting with the medical associations about coming or bringing them into the public plan. And that's why I said the deal that they struck at that time, the so-called accommodation, was that, you pay the money and then you bug out. We get to call the shots about when we see, how we do it, how we run it, when we, and so some of us would say now that our system is really organized more around the convenience of healthcare providers than really about, the needs of patients, because they do run their own ships to a large extent. So we have had resistance from healthcare providers. That is quite the usual story that's happened in countries all over the world where you've seen universal healthcare come to pass. Big strikes and a big strike in the Canadian context, multiple strikes actually over the years, but in the UK, New Zealand, same deal. Australia, physicians worried about losing their income streams.
It's interesting because, of course, that was the same case in the United States, and the American Medical Association vehemently fought, quote, socialized medicine, whatever that was, or earlier versions in the 60s. And yet in Canada, the resistance of the physicians was overcome, whereas in the US, it triumphed.
Yeah, there's blood on the floor, that's for sure, though. And it has had a lasting legacy, right? The accommodation that has been reached between the sort of government and the physician associations means that perhaps, things like someone was asking in the chat about wait times. Could we get rid of wait times? Yes, we could. Why don't we? Because we would actually have to ruffle a few feathers to make that happen. And governments don't want to ruffle the feathers of physicians, and physicians are, reasonably happy with how things are. So
the other thing to throw in, Bob, and I know the time's getting on. Again, I'm going back to my soapbox of comparing, treating like cases alike in different cases differently. And there are many physicians. As I said, I came to Ottawa, and it took me a year, my wife and I, a year to find a primary care doctor who would see us. Now here's my other show and tell. Here's my Ontario health card, which says that I can go in and get a doctor to look after me. Well, it doesn't say here is your doctor. It says the fees that your doctor charges you will be paid for by the Ontario Health Insurance Plan. And that's not to criticize Ontario's health plan as opposed to Alberta's, but among the things that are sometimes shuffled off to the side is the difference between the need for primary care as a basic and fundamental platform or level below which people cannot fall, and the various specialties. I worked at a hospital early in my career in downtown Toronto, and the specialists were very frustrated. Many of them left and went to the United States, where they felt they could have a better working condition, or whether they felt they were being paid enough or not enough is not my business to say. But there is quite a worry here about the concentration of clinical care in the large cities, Toronto, Vancouver, Montreal, Ottawa, Calgary, Edmonton. Our largest city is Toronto, and it has 5 or 6 million people. It doesn't have the 8 million and change that New York City does. But that's why I was showing you comparing likes and likes. Ottawa is the same size as Indianapolis, yet there are many more providers of primary care in Indianapolis than there are in Ottawa. Why is that? Well, there are actually reasons why that we can't get into today. We also have very little care in the far north with our Indigenous population, who have to sometimes fly at government cost to a major center in the south for, say, cancer care. So the specialty issue is its own unique little ball of wax here that gets tied up in it. I don't know if Colleen has more on that as well.
I just want to make a comment about wait times, Bob, if I could, because there's a question in the chat about wait times, and it's come up quite a bit. I have studied, done comparative work looking at wait times across different countries and how we can tackle them and what are the causes and so forth and so on. So when I first came to Canada 25 years ago from New Zealand, wait times were not an issue at all in Canada. And wait times in New Zealand were really, really long. And so Canada seemed to me to be sort of like this, beautiful, fantastic place, and how wonderful this was. And so I was, one of the many reasons I fell in love with Canada was it seemed to me that the Canadian healthcare system was terrific. But over time, things have deteriorated in terms of access, particularly around primary care. And I just want to mention, though, I don't think that is because of governments cutting back and not investing enough or being too mingy. It's things like, as I said, the physicians themselves added in Ontario about 10 or 15 years ago, added an extra year of training unilaterally to become a family doctor. And so one whole year of doctors disappeared. There's no, this was their decision. They did it. There's no planning for that. There was no, anticipation for it. It was a huge shock to the system that I think we then spent quite a bit of time recovering from. We've also seen the feminization of the profession. And as we've actually tried to pay family doctors more because we want to value them, this actually means that you can make a really good living working 3 days a week. And, my friends who are family doctors, many of them don't want more patients because they don't want that. They want to work a couple of days a week, take home 200 or 300K a year and live a pretty good life, right? So even although the numbers of our doctors have been increasing, the actual number of patients and hours that they're doing are very low. So this is not the case, for example, in the UK, where all the doctors and so forth, because they're actually employees of the state, there are contracts and arrangements that are made with them to make them have to work a certain number of hours and put in a certain amount of time. So here we see the sort of similarity or the kind of ethos with the US and the Canadian milieu, that we let our doctors have more freedom. But, we do have the consequences then of maybe sometimes it's not so great for patients. And we really have to solve this because, as Eric said, it's just absolutely ridiculous that given the money that we pay, that everybody doesn't have access to primary care, in a country as wealthy as Canada. So we've really got to kick this one to the curb and figure it out tout de suite. That's the only French I'll say tonight, but I could do a little more.
Well, we're out of time, unfortunately. It's been a wonderful discussion. I would just say that we may be comparing apples and oranges in terms of solutions, but the problems are so much the same in terms of, underfunding for mental health services, underfunding for various groups, wide differences between states and policies, we're now seeing with abortion, et cetera, et cetera. So there's a lot of similar problems, even though we may approach them from somewhat different reasons for, as we've been saying, complex reasons. I was also going to say that I was struck by the comment of Tristram Engelhart and his carrying his gun. Of course, he was from Texas, as I recall. So those of us in New York feel that's in some ways a much further country from us than Canada is. This has been a terrific conversation, I think. So first, I want to thank so much both of you, Colleen and Eric, really for wonderful thoughts and insights and generosity with your time and wisdom. And I want to thank the School of Professional Studies and the team, Karen Schimmel and Athena and everyone who helped make this possible behind the scenes, and also all of you who joined us. We also have an event coming up of an alumni panel of students from our program, some of whom are from Canada, coming up next month, and a session on June 30th on moral distress among nurses and what we can do about it. People proposing different solutions to help address some of the moral distress that nurses, both Canada and the US, have been facing with COVID, etc. So again, thank you all. And with that, I wish you all a wonderful evening. So again, Eric, Colleen, thank you. Take care, everyone. Good night.
Thank you, Bob. Thanks, Colleen. Cheers.
Thank you.
Cheers.